Hello. Yes, Kartik. So I think we'll start the class. So I will introduce you first. Thank you everyone, whoever is attending. I thank you once again. Today's our speaker is Dr. Kartik Krishnan. Dr. Kartik is associate consultant in head neck surgery department at HNCI Mumbai. And Dr. Kartik will be speaking on the topic, the classification, diagnosis and management of carcinoma ear, that is temporal bone. So I hand it over to you, Dr. Kartik. Please go ahead with your presentation.
So, ma'am, you can see my screen?
Yes, I can see. Yes, please go ahead.
Okay. So, good morning, everyone. At the outset, I would like to thank Dr. Poonam Joshi, madam, for giving me this opportunity today to present briefly the diagnosis, classification, and management of carcinoma ear. So, temporal bone cancers or malignancies are very rare. But if you see in PubMed, there are around 6,828 results which we can see if we type temporal bone cancer. But majority of these results are retrospective studies and case reports, and they all range from a wide, like the years of range of years is quite wide. So it can be 40 years, 50 years. So over a period of time, the treatment has evolved. So we are not currently understanding what is the best treatment for these cancers, as well as how it's the prognosis of these cancers are. So the temporal bone cancers form around 0.2% of all head neck cancers. Generally, if you see as a ratio, it is one out of 5,000 to 20,000 patients who present to us with otologic complaints. The worldwide incidence, if you see, is estimated to be around 1.3 cases per million. And the most common cancer of the temporal bone we see is squamous cell carcinoma. Others are like basal cell carcinoma and adenoid cystic. So, temporal bone malignancies, as such, the primary site of origin in the temporal bone is less as compared to the surrounding site. So, if you see that the ear canal, 15% give rise to the temporal bone malignancies, while the malignancy can arise in the bone itself is only around 10%. And from the surrounding sites like parotid gland, periauricular skin, that is the skin of the pinna, the skull base. These are the sites where the tumor can go into the temporal bone. So generally we see the cancer arising from the surrounding sites going into the temporal bone. Why is this important to know where the site of origin is? Is because of prognostication. So we see that the primary external auditory canal tumors, they have a better prognosis as compared to your auricular or periauricular or parotid tumors that affect the temporal bone. So it's important to know the site of origin. What are the various histologies that can be found in the temporal bone malignancies? So you have got the squamous cell carcinoma, which is the most common. Others are the ceruminous adenocarcinoma. These are all arising from the ceruminous gland. So we all know that there are these ceruminous and sweat glands located in your external auditory canal. So the salivary gland malignancies can arise here. So adenoid cystic, mucoepidermoid, pleomorphic adenoma. And then as you go inside, you have got your middle ear malignancies. So it can be middle ear adenoma or adenocarcinoma. And internal ear, you have got the endolymphatic sac tumor, vestibular schwannomas, and meningiomas. These are the primary tumors of the temporal bone. If you have tumors arising from the parotid or any other mesenchymal tumors, like even rhabdomyosarcomas or other sarcomas, can also arise from the surrounding structures. So, coming on to the etiology of the temporal bone malignancies. So, the most commonly we see in patients with long-standing history of chronic otitis media or malignant otitis externa. So, these patients have got long-standing otorrhea, and because of secondary transformation of the mucosa, because of the continuous irritation due to the infection and the inflammatory reaction, the temporal squamous cell carcinoma can arise. Cholesteatoma is also known to be a risk factor. Nowadays, research is showing that even HPV is common in the middle ear and temporal bone cancers, especially HPV 16. And radiation exposure is a very important factor, especially where long-standing history of radiation in childhood. So that can give rise to your sarcomas and sarcomatous carcinomas. The patient with temporal bone cancer, so they generally, a triad is described of hearing loss, otalgia, and otorrhea. But this triad is classically found only in 10% of patients. So, hearing loss. So, the timing, the symmetry, and the functional impact should be assessed. So, whether both ears there is a hearing loss or it's only in 1 year, and how much time, whether it's a sudden hearing loss or there are associated oral fullness, autophony, or pulsatile tinnitus. So the type of hearing loss can give rise to where the tumor is. So if it's a blocked ear or there's tinnitus heard, then it's in the external auditory canal or middle ear. Or if there is a coincident vertigo or sudden complete hearing loss, then it will show that it can be in the inner ear because of vestibular involvement. Then otalgia and otorrhea can also be in infectious processes like otitis externa or otitis media. So if any infection which generally does not respond to antibiotics within 15 or 2 days or 1 month, then we should be very careful and investigate for a temporal bone malignancy. Facial weakness, that is because of facial nerve involvement, is one of the most commoner in symptoms of temporal bone malignancy and a severe sign. So it can be gradual onset or sudden onset or even transient episode. If there is any inflammation because of the tumor, it can compress the facial nerve in its canal. And if the inflammation is resolving and waning, then you will have transient episodes of facial weakness. This is generally found in 4 to 64% of patients. And other symptoms which a patient can present is with dizziness or vertigo, as I said, because of inner ear involvement or involvement to your lower cranial nerves at the skull base. You can have dysphagia or dysphonia because of 9th and 10th cranial nerves, and dysarthria because if there is involvement of the hypoglossal. So coming on to the examination of these patients, so you have to do a thorough local examination. So as in any ear examination, we have to involve the examination of the pinna, the external auditory meatus, the external auditory canal. As we all know, the external auditory canal has got two parts. One is bony and one is cartilaginous. So complete evaluation of both these, where the tumor exactly is located has to be noted. The involvement of the tympanic membrane and in tumors which are further in like in the middle ear, you can see that there can be some redness of fluid inside the middle ear, or even a pulsatile mass can also be seen in primary middle ear tumors. Endoscopic or microscopic examination is very mandatory to understand the entire extent of the tumor. And along with this examination, you can also do a biopsy to confirm your histological diagnosis. This is very important for further management and treatment planning. Then you have to local examination will also involve the regional examination. So the parotid. So parotid is the first acheloid node of the temporal bone cancers. So there can be involvement of the parotid due to direct extension, or there can be nodal involvement, which generally cannot be palpable. So you'll have to look at the imaging. Then you come on to the neck examination. So generally, level 2 is the most commonly involved neck nodes in your, if your antero-inferior or the inferior wall of the EAC is involved. In posteriorly based lesions, your level 5 and occipital nodes will be involved. So complete palpation of all these levels should be done when you are examining the neck. So generally, as I said, when the tumor is located in the anterior half of the EAC, it will go into the parotid or into the periparotid nodes. Inferiorly, it can come onto your upper deep cervical nodes below in your level 2 and level 3. And when it is posteriorly located, it will go into your postauricular or occipital gland. Then a complete cranial nerve examination should be done, especially of your facial nerve. The facial nerve, any paralysis should be documented using your House-Brackman grading scale, which every one of us know. It is generally divided from grade 1 to 6, depending on the severity. So more severe, it will again go from 1 to 6. So we have to note down how much is the paralysis. Then you have to do the gait testing if patient complains of any dizziness or vertigo, and an audiometry or tympanogram is a mandatory test should be done before you start any treatment. So you have to note down whether there's only conductive deafness or there's a sensorineural hearing component. So conductive will be whenever the tumor is obstructing your the sound in the external auditory canal or in the middle ear, and if it's involved the ossicles, while your sensorineural will be if it is involving your middle ear. Tympanogram will let you know whether there is any fluid in the ear, so that will show you as a B-type tympanogram. So next we have now once we have evaluated the patient and we have found that he is suspecting to have a temporal bone malignancy, as in any other cancers of the head and neck, we would next do an imaging and a workup further. So we have got both high resolution CT scan of the temporal bone and MRI. So it is known that both are complementary to each other and they both give good diagnostic information for further treatment. So coming on to CT scan, CT scan is the most sensitive for detecting the bone erosion as in any other site. However, it cannot differentiate between fluid and inflamed mucosa from tumor in the middle ear and mastoids. However, it is helpful for examining the perineural invasion as it can show your widening of neural foramina. So whenever you are suspect in cases of adenoid cystic or even in squamous cell carcinoma where perineural invasion is known, you can look at the foramina in the skull base. If any widening is seen, you know that yes, there can be perineural invasion. Then you make use of your MRI. So MRI has got good soft tissue details. It is essential for tumors that are producing nerve weakness or that invade the dura, and it gives better resolution of your disease affecting the parotid, the TM joint, and the petrous apex. And it will also tell you about perineural invasion. So both HRCT and MRI should be done in cases of your temporal bone malignancies, as both are complementary to each other. When is a PET scan needed to be done? So generally we recommend or literature recommend that PET scan should be done at high stage tumors, that is T3 or T4, as they have got higher risk of distant metastasis. And even we should do it because we will know the exact location of the disease, as these diseases cannot be clinically located. So PET scan can be done in cases of higher stage disease. So it's important to know the natural history and roots of spread. So coming on to the anatomy of your temporal bone, so you have got an external ear which comprises of your pinna, the external auditory canal, and then you have the tympanic membrane. And finally, you have got the middle ear which consists of your ossicles. It is divided into three parts: your epitympanum, that is also the attic, your mesotympanum, and your hypotympanum. So hypotympanum, you can see this jugular bulb which forms is lying in the floor of your hypotympanum. And then you have got the inner ear which have got your cochlea and your semicircular canal. This is the inner ear. So the bony canal, now the EAC is formed of two types as I told you. One is the cartilaginous part which is the outside 1/3, and your inner 2/3 is your bony part. So the bony canal and the tympanic membrane both act as a barrier for your tumor spread. So once these two are invaded, then the tumor has got a very easy pathway for spread further. So whenever a tumor is lying in your external auditory canal, it can spread through. One is posteriorly into your mastoid cavity, mastoid bone. Then once it goes medially into your middle ear through the tympanic membrane, it can go through the thin tegment tympani into your bone, brain, and into your cranium. It can go inferiorly into the hypotympanum and your jugular bulb. And you have to know there is One is fissure of Santorini. This is located in your cartilaginous canal of the EAC. These are small pathways which where tumor can go into your parotid and periparotid areas. And the next is a foramen of Hashke. So this is because of incomplete fusion of your ossification centers of your bony canal. So they are found in generally 6 to 20% of the population. Through this, the tumor can go into your TM joint area and into your parotid. So these are two important anatomical structures which you know that where the tumor can pass into the nearby area. So fissures of Santorini and foramen of Hashke. So this is the roots of spread from where the tumor can go into surrounding structures. Now, next we come on to staging. So, AJCC does not have a different staging system for your temporal bone malignancies. It gives you staging only for your cutaneous squamous cell carcinomas, which go into the temporal bone. So, in case of the staging for temporal bone tumors, we use something called as Pittsburgh staging. So, the initial Pittsburgh staging was given by Arriaga et al. So then it considered now the important difference between your modified Pittsburgh staging and original Pittsburgh staging is the facial paresis. So in the original staging, facial paresis was T3, which was later we saw that once the facial nerve is invaded, we know that the prognosis is poorer and the tumor is more aggressive. So Moody et al. He modified the staging and he got this facial nerve paresis into T4. So currently we should what staging we should know is modified Pittsburgh staging. So T1 is tumor very limited to the EAC without any bony erosion or no soft tissue involvement. T2 is very limited, that is not full thickness bony erosion or very limited soft tissue. So they see how much soft tissue is there, thickness is there. So it should be less than 0.5 centimeters involvement. T3 is erosion of the complete EAC bone or very limited soft tissue involvement or tumor going into your middle ear or mastoid. So this is your T3 and then extension further into the local surrounding structure. So that is inner ear, the petrous apex, the medial wall of the middle ear, a carotid, jugular, foramen dura, and the facial nerve paresis. This all comes into T4. Nowadays, many are proposing that T4 should be further subdivided into T4A and T4B, depending on your evidence of facial paresis is present or not. So T4A will be without facial nerve paresis, and T4B will be with facial nerve paresis. Because studies have again showing that facial nerve involvement is a very poor prognostic factor. Coming on to nodal classification, so N0 is no regional nodes involvement, and N1 is a single node less than 3 centimeters, N2A and N2B. N2A is 3 to 6 centimeters, a single node, N2B is multiple ipsilateral metastatic nodes, N2C is contralateral metastatic lymph node, and N3 is a lymph node more than 6 centimeters. So T1, T2, T3, N0 are what stages 1, 2, 3, and any nodal involvement or T4 disease is stage 4. So even nodal involvement is directly involving becoming stage 4. So now let us, by looking at some few scans, let us revise our imaging and staging. So this scan is of a tumor involving a right external auditory canal. So as you can see, this tumor is in the right EAC and it is very close to your tympanic membrane. So this suggests that this is a T1, T2 lesion. It's not involving your middle ear and even your bone. It's not a full thickness bony involvement. So then this will be somewhat as a T1, T2. Let me show it to you again. Okay, so the right side you can see the soft tissue. Now, this is a coronal section. This is a scan of a patient who complained of a right EAC mass again. So you can see this is the right side where the laser pointer is pointing. This is the tumor which you can see. And it is almost involving your tympanic membrane. So this is coming into your middle ear. So this you can consider it to be a T3. Means just as you can see, it's very close to your ossicle. So this is a T3 tumor. because it's involving your middle ear. So T1 is just in the EAC without any bony involvement or soft tissue involvement. T2 is when your whole bone it's involving entire bony canal or more soft tissue more than 0.5, and T3 less than 0.5, and T3 is into the middle ear. Then this is a MRI of a patient which is as you can see, having an extensive disease going into your parotid, the whole of the petrous area encasing your carotid. So this is a T4 disease. The same patient coronal section. This will show, this MRI showing intracranial involvement. So as you can see, let me just pause it and take it behind. Yeah, so you can see it has gone even intracranially and it's very close to the dura. So further studying the scan, we'll know whether it's intradural or extradural. Mostly this is looking like intradural. So you can see how the tube, there's a very large growth in this area. So this is T4. So after we have done the imaging and a complete workup, as I told you before, biopsy is a must to know what histology are we dealing with before we proceed. Now, management. So there are surgery, radiation, and chemotherapy. These are the three options available in cases of treating a temporal bone malignancy. Generally, the dictum is stage 1 tumors, surgery alone can suffice. Stage 2 onwards, you have to consider surgery followed by adjuvant radiotherapy or plus or minus chemotherapy. And in unresectable disease, generally upfront chemoradiation is preferred before any other modality of treatment. So, a surgery. What are the surgical options available? So, traditionally, these are the different surgery options. Sleeve resection, LTBR is lateral temporal bone resection, STBR is subtotal temporal bone resection, TTBR is total temporal bone resection. So, what are the different, so what structures are removed in different surgeries? We should know. So sleeve resection is when only the skin of the EAC or the cartilaginous part of the EAC is removed. So this is done and your tympanic membrane and the bony canal is intact. So this is called as sleeve resection. Then next is lateral temporal bone resection. So it is en bloc removal of your cartilaginous and the bony EAC along with your tympanic membrane and the malleus and incus. And then you can do a parotidectomy and a neck dissection at the same time. Condyle may or may not be removed depending on the disease status. So this is your lateral temporal bone resection. And your subtemporal bone resection is you go beyond further. So you remove any tumor in the middle ear along with your mastoid, the otic capsule, and your medial aspect of the middle ear. And depending on the spread of tumor, you might remove your facial nerve, any involved dura, or your contents of the ITF. And your total temporal bone resection is complete resection of your petrous apex also. And then depending on the spread, you might have to remove your jugular foramen, carotid, dura, brain. So further now diagrammatically representing all of the same, lateral temporal bone resection. This is the most common tumor done for your EAC tumor. So the disease has to be limited to only your external auditory canal and with no involvement of your middle ear. So as you can see in this diagram, you have to en bloc remove your, so this red line, red thing you can see, you are removing the en bloc external auditory canal and your middle ear structures, which are your malleus and incus, along with your tympanic membrane. So this is your lateral temporal bone resection, which is the most commonly done for your tumors confined to the EAC. Then you come on to your subtotal temporal bone resection. So this is done for the tumors which are involved in your middle ear. So you have to remove your external auditory canal, your middle ear, and your inner ear, the structures involving your cochlea and the semicircular canal. So this is subtotal temporal bone resection. Your petrous area and your carotid and all is not removed. And nowadays, people are saying there's something called as modified STBR, in which you remove only those structures which are involved. So instead of directly jumping in and removing your complete inner ear, you save it. If your disease is only limited to your middle ear and your inner ear is completely free, then you need not remove those structures. So that is called as modified STBR. Sleeve resection is rarely done nowadays. Only if a patient who comes with a very small T1 tumor, which is only in your cartilaginous portion and not going very deep, you might consider doing a sleeve resection, where the complete skin of the EAC is removed along with your cartilaginous part. The bony part is preserved. So this is your sleeve resection. So contraindications to this surgery are if the disease is going into cavernous sinus, massive intracranial, unresectable neck disease involving a carotid, distant metastasis, and poor general condition of the patient. All these areas we won't do surgery. Then what are the other procedures performed along with your temporal bone resection? So parotidectomy. So as we discussed further, your fissures of Santorini can give spread of your tumor into your parotid, and even the lymphatic drainage of your EAC is to the parotid nodes. So superficial parotidectomy is generally performed with LTBR for advanced stage EAC and pre-auricular skin malignancy. You will can avoid early T1T cases which are not involving your anterior inferior wall. So diseases which is located posteriorly and in early T1T cases, we might avoid a parotidectomy. But in any other case, we have to do a minimum superficial parotidectomy. Neck dissection. So historically, the temporal bone malignancies, the primaries arising in the EAC or middle ear, they generally have a low rate of cervical metastasis. However, nowadays it is considered that neck dissection should be done because it acts as a staging tool for determining the need for adjuvant therapy, whether we need to consider, and also it gives you exposure of vessels if you are considering a microvascular free tissue transfer. So for these reasons, elective neck dissections of level 2 and 3 are generally done along with your temporal bone resection. The studies have been done even on prevalence of occult node metastasis in squamous cell carcinoma of temporal bone. So this is a systematic review and meta-analysis of 13 studies involving 550 patients of temporal bone cancers. 267 patients underwent neck dissection, and they saw that the total occult metastatic rate was 14%. And they saw that higher the T stage, there were higher chances of nodal metastasis, and mainly the metastatic disease was found in level 2. Then once we have done surgery, the reconstruction of these defects is very critical because patient will require adjuvant radiotherapy. So healing is very important, and we have to prevent any further complications. There can be exposure of your other deep critical structures like your vessels and inner ear. Hence, reconstruction is very important. Goal is to not means we have to avoid any open cavities being remained behind. So we can make use of both local flaps and the free flaps. Local flaps like temporalis flap is suited for most LTBR defects. So lateral temporal bone resection, more defects you can do away with a temporalis flap. But for larger defects, a microvascular free flap is necessary, in which your anterolateral thigh flap is the most preferred because it gives good bulk and soft tissue for the reconstruction. Management of facial nerve is a very important aspect of your treatment because, as we all know, the morbidity of facial nerve paralysis is too much. Eye closure becomes a problem because of which you can have corneal irritation, corneal ulcers, and you can have permanent visual damage. It can also, because of involvement of the facial muscles, patient can have problem in mastication, patient can have problem in eating, there can be drooling of saliva. Aesthetic problems are there only. So because of all this, management of facial nerve is very important. So if a patient has got a normal pre-operative function, then immediate nerve repair is recommended. So if you can have the now this in itself is a separate topic of discussion. So facial nerve reanimation and facial nerve management, you need to have a separate lecture because it's a very important topic to be discussed. So if you have the stumps of the nerve, then you can do a primary repair. If both the stumps of the nerve are not close, you can get in a different nerve and use it as a nerve graft. Or if you cannot get the nerve, there are different, and in pre-existing facial paralysis, you have got different animative procedures like static slings, gold weight implants, and you have got dynamic and static reanimation. So all this can be done for facial nerve management. Now, before we go on to the adjuvant treatment, in especially in temporal bone malignancies, because orientation of the specimen is very difficult. The tumor lying deep between, surrounded by bone everywhere, the pathologist may not be able to correlate properly your margins and your margin status. And as we all know that in any head and neck malignancy, your margin status is very important. Hence, an excellent communication must be maintained between your surgical and diagnostic teams. The exact site of involvement, what landmarks are there, that all should has to be understood. So there is a concept called as macroscopic examination once your surgery is done. So what is the aim of the macroscopic examination? It is to record the dimensions of the specimen, to know the physical characteristics of the lesion and its dimensions, the extent of involvement of your adjacent structures, any assessment of margins, and to allow selection of tissues for histologic examination. So this is all the aims of your macroscopic examination. Hence, there is an international collaboration of cancer reporting, ICCR. They have come up with a data set for reporting of ear and temporal bone tumors. So you all can go through this, in which they have clearly said how to orient the specimen, how to key for LTBR, STBR, what all are the different structures we have to send separately to the pathologist to read and to study. So this is a very good article which you can all go through. Now coming on to your adjuvant treatment. So first is radiotherapy. So what are the indications we consider for adjuvant radiotherapy in temporal bone cancers? So you have got positive or close margins less than 5 millimeters, any nodal involvement with extracapsular extension, T3 or T4 advanced disease, and the presence of perinodal and lymphovascular invasion. The general doses which are given in an adjuvant setting are 60 grays to your postoperative tumor and involvement. That is your CTV, clinical tumor volume. Then 56 to 58 grays to your surgical bed and clinical high risk area. That's your planning PTV, planning tumor volume. And 54 grays to your undissected areas and to your nodal basin. So these are generally the doses given after a surgery is done. Can definitive radiation also be considered if surgery is not possible? Yes. So this is a study done by the Tata Group, Sarvani Ghosh et al. So it's an audit of patients of 89 patients who were treated with radiation. 65% patients received adjuvant RT, while 24 patients received definitive RT. And they showed that on multivariable analysis, patients receiving adjuvant RT were associated with superior outcomes as compared to patients receiving definitive RT. Okay, so adjuvant RT was shown, so was shown to be surgery followed by adjuvant RT was associated with better outcomes than definitive RT. So surgery followed by adjuvant RT should remain the mainstay of treatment. And they also showed that IMRT has shown to reduce the morbidity of patients, and intensity modulated radiation therapy should be used to reduce complications rather than your conventional 3D CRT. And chemoradiation for upfront unresectable squamous carcinomas has also a role, as shown by this meta-analysis. So it's a meta-analysis of 752 patients, but 74 of them had locally advanced disease, where definitive chemoradiation was performed in 37 patients. And they showed that patients who underwent definitive CRT, the 5-year overall survival was comparable, as they compared it with the standard of care, that was surgery followed by adjuvant RT. However, despite patients having unresectable disease and poor prognosis. So, in spite of having unresectable disease, by giving them chemoradiation, there was a good response seen. So, the overall survival was 43.6%. So this meta-analysis showed that there is some role of definitive CRT and it should be considered in patients who are having unresectable disease. Then coming to chemotherapy, in a neoadjuvant setting, you can consider what are the agents, taxanes, 5-FU and cetuximab. In the concurrent setting, cisplatin is the most commonly used agent. If you are considering a basal cell carcinoma, there is something called as a Boden's homolog receptor, which is found in basal cell carcinomas. So SMO inhibitors, that is bismodegib and sonidegib, these are the drugs which are considered in basal cell carcinomas. And for adenoid cystic, you might consider cisplatin and vinorelbin and CAP, that is cyclophosphamide, adriamycin and cisplatin. So these are the agents which are generally used for the different histologies. Is there any role of neoadjuvant chemotherapy? So not much studies have been done. This is one of the studies in literature by again done in TMH by Amit Joshi et al. So this is the study of 4 patients. 3 patients received 3 drugs and 1 patient received 2 drugs, cisplatin and Pacli. All 3 patients who received TPF achieved a partial response, and out of these 2 patients could be operated, and one was able to undergo surgery, and even the patient who received 2 drugs also was able to undergo surgery. So, but this is a very small study and much cannot be told about. Nowadays, there are many studies. There is a study even comparing your neoadjuvant immunotherapy, but that study is not done well, and hence I did not get it here. After now, we should know how does the prognosis and the survival pattern of these temporal bone malignancies happen. So there are good prognostic factors like any lack of immunocompromised status, basal cell carcinoma histology is a good prognostic factor, absence of PNI, LVI, and if the disease is limited to your EAC, so patients who undergo LTBR have a better prognosis as compared to your STBR and modified STBR patients. Poor prognostic factors are advanced diseases, T3 and T4, the facial nerve involvement, and close and positive margins. So as we go from T1 to T4, your survival decreases. So T1, the survival is around 80 to 90%. T2 is 60 to 70%, which becomes dismal only around 20 to 30% per T4. So to summarize, squamous cell carcinoma is the most common malignant tumor of the ear canal, middle ear and temporal bone. Hearing loss, otalgia and otorrhea are the classic triad of symptoms the patient presents with. Cross-sectional imaging, either CT or MRI or both is required to evaluate the extent of disease. The modified Pittsburgh staging is used for these tumors. Surgery is the primary treatment for these tumors, especially for early stage disease. Post-operative radiotherapy is indicated for tumors stage T2 and higher, recurrent lesions, and for patients with positive margins, PNI, bone invasion, and lymph node metastasis. Pre-operative chemotherapy and radiotherapy has an emerging role for late stage, that is T3 and T4 disease, and overall survival still remains low for advanced stage disease. Thank you for your patient listening.
So thank you, Dr. Kartik. Actually, it was a very comprehensive and detailed lecture on the topic of carcinoma ear and temporal bone. Thank you so much. Dr. Kartik, there are a few questions in the chat box. I will read them to you. So what will be the treatment for adenoid cystic carcinoma of parotid involving both lobe of parotid with the involvement of cartilaginous external auditory canal?
Okay, so if we are first of all we have to do an imaging. So as I said, we have to do both CT and MRI. Now in your case, you are saying that basically the tumor is of the parotid going on into both lobes of parotid and cartilaginous EAC. So for this patient, your treatment will be you have to do a total parotidectomy. Depending on the pre-operative facial nerve function, it will be sort of conservative or radical parotidectomy if your facial nerve is involved on scan or during surgery. And plus, you would have to consider a lateral temporal bone resection because the disease is going into your EAC. So a minimal lateral temporal bone resection should be done. So in short, if you to summarize, it will be a lateral temporal bone resection with a total conservative SOS radical parotidectomy, and you can consider a temporalis flap for the reconstruction with a neck dissection of levels 2 to 4.
Yes, thank you, Dr. Kartik. So there is another question. Is there any role of neoadjuvant chemotherapy in the management of EAC squamous cell carcinoma? I think you showed us that paper also. So role of neoadjuvant chemotherapy.
Yes, so as I showed you, generally if the disease is upfront resectable, we should go ahead and do the surgery. Surgery followed by adjuvant radiotherapy is the primary modality of choice. But in cases if you are T3 or T4, in which you feel that the disease is too advanced and your surgery will be very morbid because of involvement of your inner ear or petrous, in those you might consider NACT if the patient has got good performance status and you feel that he will be able to sustain the entire course of chemo, and if it responds well, you might then go ahead with chemo radiation or surgery later depending on your the post chemo status. So as such, neoadjuvant chemotherapy, if you say now, has not got much of role. If you have got unresectable disease, you should give upfront chemo radiation and not anything.
So another question is facial nerve pre-op not involved and functioning well, but looks like encased on table. So should we sacrifice and reconstruct or try to separate it from the tumor and preserve? So I think they are trying to ask you like that if should we go with R0 or should we just shave it off from the nerve and keep it intact like we discussed, and there is like always this debate going on in parotid surgeries also.
Okay, so now if it is now we will divide it into squamous cell carcinoma and adenoid cystic. If it's a squamous cell carcinoma and during surgery, if you find that the disease is very close to the nerve, as a surgeon, if you have an experience and if you feel that you can shave the disease of the nerve rather than means trying to completely resect the nerve, then and the disease comes off by shaving, then we need not resect the nerve, and if the facial nerve function is intact, then we should preserve the nerve. But if we feel during surgery that the disease is going into the nerve and the facial nerve sacrifice is necessary, then we should go ahead and we should immediately repair the nerve. And it has shown that immediate facial nerve repair has a good prognosis, and the recovery of the facial nerve is up to grade 3, and patient will be able to close the eye. While in adenoid cystic, where you know that perineural invasion is known, then MRI will give us a good slippery of finding, and depending on that, we can treat the nerve.
So the last question, Dr. Kartik.
Yes.
See, what is the unresectability criteria for temporal bone malignancies?
Yes, so madam, as I during the lecture, I showed those unresectability criteria. So any disease which is going into a cavernous sinus involving your carotid and anteriorly, then which is having a lot of intracranial involvement and involving your brain parenchyma, then a very poor general condition of the patient, and if any nodal disease involving your carotid. So these are generally, and involvement of petrous apex. So these are generally the unresectable criteria. And this has to be removed from you.
So I think Dr. Kartik, I think with this we conclude today's lecture. I thank you once again. It was really an insightful lecture, and you patiently answered all the questions. And I really thank you.
Yeah. Thank you, madam, for giving me this opportunity, and thank you everyone for your patient listening. Have a good day. Thank you.
Thank you.
No, we're done. So I was trying to tell you.